Good evening, one and all. So let's start off with the next session. So basically, it's battling of the Bantings. It's very difficult to treat the infants. First of all, infants, whenever the infants come, very difficult to manage these infants. And you have to know where you have to refer these children when they come, and you need to know how you examine the children. So I would request Kaushik Murli sir to come over, a well-known pediatric consultant from Shankara Hospital, Bangalore. And today my co-chair is Dr. Anju, and our ever-time dynamic head of the department from Pediatric Ophthalmology in Commonwealth Hospital, Laila Madam, is with me. So let's soon start off with the first session. I would request Dr. Anju to speak on neonates with lacrimation. What is the oculoplastic perspective in dealing with these children?
Thank you, madam. Good evening, everybody. I know that we are at the very fag end of our academic sessions, and all of you must have had high volume academic inputs through the day. So I'll keep the topic quite simple. It is basically just to revisit those diagnoses that you would have forgotten. So a neonate with lacrimation and oculoplasty perspective. So these are the clinical pictures of two children. The one on the left has got occasional watering according to his mother, and it is relieved with medications. While the child on the right has persistent watering in the right eye with discharge. So which is which? That is, we know that there are two conditions called hyperlacrimation as well as true epiphora. So the child on the right was a case of hyperlacrimation. He was having allergic conjunctivitis. Exposure to dust worsened it. While the child on the right was having a congenital nasolacrimal duct obstruction, which was present soon after birth. So what do you mean by hyperlacrimation? It is basically excessive watering due to reflex irritation of the cornea and the conjunctival surface, which will be dealt in the following talks. Whereas today I'll be talking about what is true epiphora. Epiphora basically means watering due to obstruction in the lacrimal outflow pathway. So history taking is of paramount importance, the duration of symptoms, the laterality of the disease, whether there was any predisposing trauma, any history of surgeries, it could be lid surgeries, nasal surgeries, or drug reaction such as Stevens-Johnson syndrome that could predispose to watering. Epiphora can be either functional or non-obstructive, or anatomical or obstructive, depending upon the site of pathology. So let's briefly go through some pictures. Look at this child. You can make out that in both the eyes there is a raised tear film. If you take a closer look, you can actually see that there is a small mound medially. Do you have a pointer? There's a small mound of skin medially that is causing the lashes to turn inwards slightly. So this is what we call an epiblepharon. It is not always... So it need not always be surgically corrected. It is observed till an age. It is only surgically corrected when the child develops recurrent corneal ulcerations and so on. This is another condition closely associated. This is a case of congenital entropion. You can see bilaterally the lids are turned inwards, and this will require a surgical correction. So we saw entropion. Now congenital ectropion is also a cause of watering, and this is commonly seen in children with Down syndrome. This is a child who has undergone bilateral tarsorrhaphy, lateral tarsorrhaphy, as well as a full thickness skin graft. In spite of that, the child has watering. So further correction will be required in the form of full thickness skin graft for both the lower lids. Some lesser known diagnoses that you come across are complete eversion of the upper lids at time of birth, which can be managed conservatively. If not, then sutures need to be taken, and also tarsal king syndrome. Now look at this child. She came saying that she had watering, but I could not exactly find any reasons. So if you look closely, there was one single lash that was misdirected, and it was irritating her cornea and causing watering. So this is another condition that we need to look for. Also, an extra row of lashes can also be present, which is called distichiasis, and these need to be addressed. This child had watering in the left eye. you can see that the eye is slightly enlarged. So I asked her to close her eyes, and this is what you see. On removing the mask, you could make out that there was deviation of the mouth to the right side. She was having a facial nerve palsy. It's a case of lag of thalamus also contributing to epiphora. Now we shall come to the anatomical or the obstructive epiphora. So the first point of outflow of tears is the puncta. So punctal agenesis is a cause of watering. Usually a single puncta agenesis will not cause much discomfort to the child. If it is associated with excessive watering, then there could be a probable underlying nasolacrimal duct obstruction which needs to be addressed. The next is the nasolacrimal duct system. So just going through the anatomy quickly. So there are two puncta and then the canaliculi, both the upper and the lower, and this drains into the lacrimal sac, and which thereafter runs as the nasolacrimal duct, which has an intraosseous part as well as a terminal membranous part. So the inferior-most part which opens into the inferior meatus has a valve called the valve of Hasner. And the most common abnormality that is associated is imperforate valve at the time of birth. So this child, at first look you would think that both eyes had CNLDO. No, this was at the beginning of dye disappearance test. This was 5 minutes later. You can see that there is retained dye only in the left eye. The incidence of symptoms in CNLDO is usually 1.2 to 30%. As you know, the triad, there will be watering, there will be discharge, there will be matting of lashes for these children. Associated facial abnormalities can also give a clue that the child has a nasolacrimal duct obstruction. The diagnostic sac, I'll just have a couple of slides. The diagnostic test is lacrimal, palpation of the lacrimal sac, whereby you can make out regurgitation. So this is a complex CNLDO where you have an dacrocystocele, which is where a reflex mechanism prevents the fluid from going back. So it is held between within the sac, leading to a bluish condition at time of birth. This is the child having an acute episode of dacrocystitis. The management remains the same. You manage initially with antibiotics. Once it settles, then you advise for Krigler's massage. Krigler's massage is basically you put hydrostatic pressure over the lacrimal sac to induce opening of the valve of Hasner. This has to be done diligently, at least 50 to 100 times a day. If it fails, then you go ahead with probing under endoscopic guidance. And in conditions where probing is not successful, the last resort would be external or endoscopic DCR. The last cause is traumatic or iatrogenic, where you have canalicular injury which is not properly repaired or any lid tears which are not properly repaired. So just revising all those diagnoses again. Thank you for your patient hearing.
Thank you, Dr. Anju, for that elaborative talk. Now, I would request Laila Madam to give her a pediatric ophthalmic perspective on lacrimation.
Thank you, Dr. Somya, for giving me the opportunity to be part of this session. So, is it on? So, all the most common cause of lacrimation or epiphora, as shown by Dr. Anju, is the commonest situation where we get tearing child with watering. So watering in an infant brings us to a more serious problem where lacrimation, photophobia and blepharospasm together, what we call the triad, where we have to doubt a more serious problem of intraocular pressure being high and enlargement of the eye and cornea which may be asymmetrical when the child is brought immediately, but when it is symmetrical, they may not bring the child immediately. Some watering may be overlooked, and when the cornea becomes hazy, only they will notice. So that is the importance of asymmetrical. They bring immediately. When it is bilateral, it is more difficult to diagnose. And when there is corneal haze, abnormally deep anterior chamber, in children usually it is very shallow anterior chamber. So when it is abnormally deep and all these features are there, then it is not difficult to diagnose congenital glaucoma. But when the classic features are not there, then we have to take all precautions to diagnose quite early, because surgery is warranted. It is an urgent step to be taken after complete evaluation and diagnosis, coming to a conclusion. So, so already she has pointed out, Dr. Anju has pointed out all the causes for epiphora. You have seen the lid abnormalities, conjunctivitis, nasolacrimal duct obstruction, the commonest, corneal exposure producing blepharospasm also sometimes. So photophobia, when there is any corneal problem with foreign body, corneal aberration, these are the commonest problems which we come across. Birth injury can also produce a tear in the Descemet's membrane and corneal edema. And uveitis, light scatter by media opacities, especially cataract in a child, can produce photophobia. And large cornea, of course, it may be a megalocornea, or axial myopia can also present with the larger cornea and the eye, and anterior megalophthalmos or keratoglobus, which appear like a ophthalmos. Corneal opacities, the commonest is corneal congenital hereditary endothelial dystrophy, where you get a bilateral picture of endothelial dystrophy, stromal opacity also will be there. Sclerocornea, Peters anomaly, infectious keratitis in a child, forceps injury, as we have seen already, it will produce a corneal opacity at the time of birth. And mucopolysaccharidosis, which comes little later. So during clinical examination, a proper family history and the time of onset of the enlargement of the eye or photophobia, watering has to be taken. And in an older child, we can also see fixing and following nystagmus is there or not, whether it has affected vision, asymmetry of the size of the cornea and aversion to light, and the slit lamp examination if the child allows you to see the anterior chamber. And glaucoma, if it is diagnosed earlier than within a month of birth, it is called neonatal, which has a poorer prognosis, and 1 to 24 months it is called infantile, and above 2 years it's a late onset congenital glaucoma. So the other associations have to be looked for: iridotrabecular dysgenesis like aniridia, Peters, Rieger's, rubella, Loeys and Lubinstein type B, where they present with cataract. We have to also look for high IOP, and sticklers, where you have to look at the retina also. Iris hypoplasia also can produce glaucoma, and some of the Sturge-Weber and other manifestations are very obvious to us at the time of presentation. And it's very important to diagnose the children with congenital glaucoma immediately. So an examination under anesthesia is the best. If it is not under anesthesia, we can see a sleeping child after fasting for 2 to 3 hours. We can ask the mother to feed the baby and then look at the eye, and also intraocular pressure can be measured if it is possible to give. It will avoid another anesthesia immediately after, before as the second procedure of surgery. So the order of examination, we do laryngeal mask anesthesia when we do EUA separately. If you have a clinical diagnosis, then you can go ahead with intubation, and you can have the examination under anesthesia just before doing surgery to know what is the corneal diameter. All these have to be seen definitely before surgery. So the order of examination in examination under anesthesia or a sleeping child will be IOP before deep anesthesia, especially when intubated and deep anesthesia is there will be a lowering of IOP. So before intubation and before struggling for intubation also, it's preferably before intubation if you are giving an intubated anesthesia. So slit lamp examination, corneal diameter, the horizontal white to white examination, fundus examination if it is possible, gonioscopy, and refraction, axial length, also a pachymetry can be done, and ultrasound axial length examination, and B-scan if the posterior segment could not be visualized, and in case of atypical findings, this may have to be repeated. I'll go through fast. IOP is very important. That is the, as we have seen, we have to see under anesthesia or a sleeping child. Perkins is best Tonopen gives a higher reading, and in infants usually we get 10 to 12 millimeter is the usual reading we get, and so higher than that we have to be very cautious. Sometimes these anesthetics, ketamine and succinylcholine produces a higher reading, and the IOP should not be adjusted for pachymetry. And IOP should not be definitely taken as the criteria to diagnose also. Fundus examination, a cupping of more than 2 is suspicious, and asymmetry of more than 2.2 is also suspicious. And after surgery, this cupping may be reversible, but you have to follow up. And some of the differentials are coloboma and morning glory syndrome. And gonioscopy in a child is a very widely open angle, but translucent, looks translucent. It can be either direct or indirect gonioscopy, and the usual pattern in congenital glaucoma is a high insertion of iris and ciliary body covering the trabecular meshwork, which gave the appearance of a membrane, and Barken's membrane was the concept before. And a flat iris surface is also seen. Look for other developmental abnormalities like iris rigors and other pathology may be there. And this is corneal diameter should be looked for. At birth it is less than 10.5 is suspicious. More than 11 millimeters you have to be very suspicious in a child at birth. And more than 11.5 millimeter by 1 year, and more a diameter of 1 millimeter above this standard norms for a child has to be suspiciously looked at. And glaucoma should be suspected in any child with corneal diameter above 12 millimeter at 1 year or more than 13 millimeter at any age. And Habs tray should be looked at with a slit lamp, and scleral thinning may be also there. And Desmond's tear in a forceps delivery, it usually presents with a vertical rupture, and in glaucoma it is usually a circumlinear or a horizontal. Axial length at birth it is usually 16.7 to 17, so above 18 has to be considered abnormal, and it has to be serially measured if you suspect glaucoma. And refractive errors are very, very common. This child had a surgery, she presented with eye drops in one eye, and IOP was very high, and look at the cornea, which is shows dense opacity, so we couldn't do goniotomy, which is ideal if cornea is clear in a child. So anisometropy is very common even before surgery or after surgery, and rapid myopic refractive shift and elongation should be looked at, and amblyopia definitely should be treated even before starting treatment, and patching instituted as soon as possible. This is a post-conjunctive conjunctive cataract surgery where the child was microphthalmic. It was a microphthalmic child presented with a ophthalmos later with watering and photophobia. So management, of course, medical management is temporary, and choice of surgery depends upon the clarity of surgery, clarity of cornea. And angle surgery is the best if cornea is clear, when we can visualize the trabecular meshwork and the iris angle. So ab interno or ab externo 360-degree trabeculotomy may be done with a suture or with an illuminated catheter, and combined trabeculotomy with trabeculectomy is the most possible when cornea is opaque, and later if it is not working we may have to do an tube shunt. So follow-up is very, very important. It has to be continued even after surgery, and the size and clarity of cornea need to be frequently assessed in a neonate, and EUA may be necessary if the child is not cooperative. Sorry for taking that time. I hope we finish before our general body. Thank you.
Thank you so much, ma'am, for that detailed talk on glaucoma and neonates. Next, we'll have a session on the retina's perspective, that is hypoxia in neonates, the air element, by Dr. Gana Ajoy, who's a retina consultant at Rani Menon's Eye Hospital, Thrissur.
Good evening, everyone, and thank you KSOS and Dr. Somya for giving me this opportunity. My topic today is air, hypoxia in neonates, the retina perspective of this. So as we all know, the elephant in the room as far as hypoxia and retina is concerned is retinopathy of prematurity, and a premature infant is in reality a fetus out of the womb. So this is, as we all know, a very blinding, potentially blinding ocular disorder that is characterized by anomalous blood vessel growth in the retina of premature infants. And India, with 3.5 million preterm births, has the highest number of preterm in any country in the world. So when we went back to 1940s and 42, 43, when Terry first described retrolental fibroplasia, that is when this disease entirety came into being. And even as early as 1950s, Dr. Patz from Baltimore, he made the observation that hyperoxia was toxic to the premature retina. What he noticed was when he went to give vitamins to these preterm children, every time at the end of say 1 month, and when he was looking at them, these children did not develop retrolental fibroplasia or ROP as frequently as the other babies did. And this he discovered was due to the interruption in oxygen that he was doing when he was supplementing these babies with vitamins. So that is when he concluded perhaps it is the hyperoxia at that point that is causing this. And he, even at that time, was able to demonstrate this in an animal model. So the 3 epidemics of ROP, the first epidemic was in the 1940s to 50s when it was due to unmonitored oxygen supply. And when there was an increased survival of very low birth weight babies, that's when the second epidemic came into being. Even though at that time they were finding that oxygen may be the cause, even then they were not able to stop the second epidemic. And the third epidemic is when heavier and more mature babies were developing severe ROP. We in Asia and India in particular are in third epidemic at this time. So, and then in 1980s, they found the pulse oximetry. And at this point, better oxygen tension monitoring was then possible. Still, the second epidemic of ROP continued. At this point, low birth weight and gestational age became recognized as the ROP main risk factors. In 2003, that is when a landmark study from Wright Foundation and NICU in Los Angeles, they found that there was a dramatic reduction of severe ROP when saturations were kept between 83 to 93% at birth, from birth, and during transport. This virtually eliminated threshold ROP. And laser in these babies in the higher SpO2 range of 90 to 98% was 4.5%, and zero for low SpO2, which means severe ROP can be prevented by careful control of neonatal environment and maintenance of stable physiologic low oxygen saturations. So what does this mean for ROP? Fetus, as we know, is hypoxic. The arterial blood pressure is, PaO2 is 22 to 24 millimeters of mercury. And when you come to a full-term baby or even a normal adult, it is 70 to 90. So look at the difference. And it is in this hypoxic environment that the retinal vessels grow from the optic nerve to the peripheral avascular retina. 13 to 15 weeks, it starts. 36, nasal side is complete. 40, migration complete on the temporal side. What happens with the physiologic hypoxic environment? VEGF stimulates a normal retinal vessel growth into the peripheral avascular retina. This low tissue oxygen levels upregulates VEGF. And when hyperoxia happens, downregulates VEGF. The hyperoxia element has happened at this point. There is not enough VEGF, stops all normal vessel growth stops and results in an avascular retina. The more immature the infant, the larger the area of the avascular retina. Prolonged exposure to this causes vasoconstriction, eventually vasoobliteration. There is ischemia happening at this point. This lack leads to a peripheral avascular retina. Over time, it becomes an overstimulation of VEGF. Proliferative phase sets in. If even at this point, even with that avascular retina, a physiologic VEGF is produced, it can still stimulate normal retinal vessel growth and baby has a normal looking retina. So at 22 to 32 weeks, vasoobliteration, proliferation at 30 to 34 weeks. If this area is very large, there's a large amount of VEGF being produced. And that is when stage 1 and stage 2 ROP set in. There is AV shunts and progression of ROP. Regression occurs if this VEGF stimulates normal vascularization, even at this point, past the AV shunt into a vascular retina. This is what we are monitoring when we are checking for ROP. Now, large areas of VEGF, large VEGF production, neovascularization goes to stage 3, stage 4, plus disease, and so on. Here, because we can target the extra VEGF, that's when we give either anti-VEGF or laser. This is when we start treating. So, physiological hypoxia, normal development. Relative hyperoxia leads to ROP. So now we have lower SpO2. We know that this can be regulated to a point. But what does this mean? it resulted in increased death rates. Despite this despite all this eventuality, that is controlling this oxygen to this extent remains controversial. Higher SpO2 ensures a reduced risk of additional life-threatening complications, even though at the expense of a significant increased risk of ROP. So increased ROP incidence appears an unavoidable consequence of a reduced mortality obtained with higher oxygen levels. This is the reason why Committee on Fetus and Newborn of the American Academy of Pediatrics suggests a level of 90 to 95% as the ideal target range of SpO2. So we know multifactorial disease. Now what can we do? What we can consider for the future is to decouple ROP from oxygen. There are hypoxia-inducible factors. Can we decouple this from oxygen and make the retina feel that it is not the oxygen that is stimulating the growth? That is the way forward. So preterm newborns seem to have a paradoxical relationship with oxygen, while on the one hand guarantees and improves their survival, but the other hand represents a signal that interrupts the vasculogenic process and therefore lays the foundation of the development of ROP. Thank you.
That was an excellent presentation. Next, we will be dealing with air, that hypoxia in neonates, a neuro-ophthalmic perspective by Dr. Lakshmi C., who is a pediatric ophthalmology consultant.
So when we resuscitate more and more babies into life, tackling all these calamities, we need to know what is the consequence of this issue with the neonatal brain. So the hypoxia boils down to a metabolic concept now, because perinatal hypoxia causes ischemia, and it is ultimately a metabolic problem with excitatory neurotransmitters like glutamate which are implicated, which causes a cascade of neurotoxicity. So when we deal with a child with neonatal hypoxia, it's not necessary that we include only the perinatal hypoxia. We need to include history like preeclampsia or PIH and postnatal, or in the first one month of neonatal life, whether the child has had any insult like hypoglycemia or bradycardia or any other cardiac arrest related issues. So this should be asked in the history, and this injury to the neonatal brain can be called as cerebral visual impairment or cortical visual impairment, and it is mainly divided into two entities. One is a term injury that happens in a newborn infant who has been delivered at term, and this involves the visual cortex and adjacent white matter. Parieto-occipital and parasagittal cortex are mostly involved in this type of injury. The second type of injury is a preterm injury coined as periventricular leukomalacia, which is associated with gliosis in the subcortical area. Imaging is the mainstay in diagnosing these children with neonatal hypoxia. It is helpful in differentiating a cortical from a subcortical injury. MRI with a T1 and T2 weighted image will show variable signal changes in a term injury in the cerebral cortex, basal ganglia and thalamus, and deep gray matter. So this is a term injury, and the characteristic feature is the watershed areas of the main cerebral blood vessels are mainly affected. So this MRI shows gliosis in the watershed areas of the anterior and the posterior cerebral arteries and the sylvian cortex. So this is a term injury. Term injury also is characterized by another feature called eulygyria, in which the gray matter stem, the gyral stems are affected. Periventricular leukomalacia is characterized by reduction in the amount of the periventricular white matter. This is a mild periventricular leukomalacia in which there is only gliosis, and these are increasing grades of PVL in which the ventricles are dilated and there is gliosis in the periventricular area, white matter. And diagnosis, how do we diagnose these children? The clinical features are quite variable because the visual loss may not be constant. It may vary from a mild to a severe impairment. Head growth might correspond with the visual development. They can present with nystagmus and variable ankle squint. Those are the conditions in which we suspect a neonatal hypoxia. And there might be associated features of cerebral palsy, cognition disorders, seizures or extrapyramidal signs along with these ocular findings. So in the clinic, these are the common scenarios that we face. A child with a global development delay and manifest strabismus or nystagmus with an established history of HIE or a hypoxic ischemic encephalopathy. The second scenario, when we see a child with a variable angle strabismus, and on probing further, the parents might give a history of neonatal hypoglycemia or hypoxia. The third scenario is a child with a refractive error. However, we treat the refractive error and the amblyopia, and despite having a normal milestones, we see the vision is not improving, so we should suspect HIE. And the fourth scenario is a child with difficulty in walking up and down the stairs with frequent falls, inability to reach out to objects, and on asking further, they might give a history related to this. So characteristically, the visual cognitive disorders and abnormalities are more manifest in contrast sensitivity and processing of information. So the A's which have to be checked in this are acuity, the assimilation, attention and apraxia that the child has. So the processing of visual information is affected in these children. So looking away from these objects of interest is another feature which we see. Light gazing, photophobia and better vision for moving objects is another feature. Color perception is better appreciated in these children. Frequent falls as we already shown. And there is a concept of ventral and dorsal stream. If the ventral stream is more involved, it is analysis of visual space which is affected, and if it's the dorsal stream, it is mostly the lower visual fields which is involved. So reduction as accommodation is another feature that we see in such children. So these are the neuro-ophthalmologic signs of cortical versus subcortical. They are quite variable. And this is a child with a cortical injury, term injury. I think this is a fusion maldevelopment nystagmus which manifests on covering one eye. The nystagmus appearing only on covering the other eye. And this is a child with a term cortical injury. This is also a latent nystagmus. I think it's not very clear, but there is a latent nystagmus on doing a cover test. So this is another feature of injury. So with that, thank you for your patient attention. I think I could make it on time. Thank you.
Thank you, Dr. Lakshmi, for that wonderful talk. Now we have covered the elements water and air. We are entering fire. Redness in neonates, a pediatric ophthalm perspective by Dr. Somya Nambiar, who is the pediatric consultant at Comtrust Eye Hospital.
So, good evening one and all. So, how many of you are general ophthalmologists here? Yeah. So, there is always a tension whenever an infant comes to you. The parents have multiple questions to ask, and we are faced with a problem like what we have to see the child, what do we do with the child, where do we send the child. So that's the initial fear that comes to everybody as a general ophthalmologist, where we have to send the patient. Okay, so basically I'm dealing with the redness in these children. So most often what we see is redness in these children. So the objective of my presentation is to describe the common and varying presentations of such children. Basically, I'm dealing with infants. Describe what is the importance of history taking in these children, and to emphasize the importance of timely reference, and to emphasize the importance of general examination. So these are the things that we can do as a general ophthalmologist. So let's see this with each case. So a 6-month-old baby comes to me with watering of eyes and discharge since 2 weeks. So what do I ask? I ask, is the child rubbing the eyes? Is the child having fever or cold? Any history of trauma? So my questions are directed towards this, and by this at least you'll have an idea what the child is having. Okay? So you may not get any history from the child. So from the parents you can get at least these 3 main things. and you find that, okay, the child is having some conjunctival congestion. You can do a torchlight examination definitely, but I would also suggest if you have an indirect ophthalmoscope, you can use a 20D and then you can have a magnified view of the child, make the child lie supine, have a magnified view of the eye, and at least you have little bit idea where the congestion is, which part of it is congested, okay? Foreign body is one thing that you should remember. Always try to avert the lid. You will not miss out this very frequently. It's very common. It's not very uncommon. But unless you avert the lid, you will miss this out. So, another case is that of a child with redness and swelling in the left eye. So, you can see this. The child is having a lid abscess, and you can see that there is a, here there's a lid abscess, and secondarily, there's a secondary bacterial infection. Because of that, there is a preseptal cellitis also developing. But if you can see, there are multiple lesions on the face also. So, it's a molluscum actually. And there was a molluscum in the lid which has got secondarily infected and caused this. This is a 3-month-old child. I don't have the picture of the child because a 3-month-old child. And the child came with bilateral severe purulent discharge. Okay, so my first thing on examination, there was definitely a diffuse conjunctival congestion. There was no other anterior segment abnormality. And I took a conjunctival swab from that. And this turned out to be a methicillin resistant staph aureus. And based upon that, and it was sensitive to moxifloxacin. So I started on moxifloxacin, no fever. Luckily the child did not have any fever, so I started on moxifloxacin and the child responded well to that. So neonates are at a high risk of conjunctivitis due to many predisposing factors. One is because of decreased tear production, because of the lack of IgA in tears, decreased immune function of the child, and absence of lymphoid tissue in the conjunctiva, and decreased lysosomal activity. So this is a case of internal hordeolum. Okay, so this is very common to see, and as we all know, you give hot fermentation, you give systemic antibiotics depending upon the age and the weight of the child, and the topical antibiotics you can start. Now another thing that you should remember, that a child, if it comes with this picture, you can see that there is a subconjunctival hemorrhage. So ask the history if there has been a, this is a 2-month, this was actually a 10-day-old child. So I just asked the history. There was a history of vacuum delivery. So that itself can cause the subconjunctival hemorrhage in such children. And always look for the bleeding parameters. You can always take the help of the pediatrician who is looking after the child and see if the bleeding parameters have been looked into. Anemia, BTCT, all that, if it is done, platelet count, how is the platelet count, that also has to be ruled out. Along with that, you have to do a dilated examination. Digitally, at least, you can check the intraocular pressure in such children. So, I had a child who was referred for redness with this kind of a picture. So, you can see that there was no history of trauma, but the child was referred, came to the emergency department telling that there is a foreign body in the cornea. But when I saw, I used the same thing, indirect ophthalmoscope. With that IDO, I just checked, and you can see that there is a small deposit here, if you can see. So this is not on the cornea, it's inside, on the endothelium. So it is a granuloma that is there. So some children can present this kind of picture also. So it's a granulomatous uveitis. We had a systemic workup for this child, and we are waiting for the results. Now a child comes with redness following fever. There is a history of corona in the family. The child had a fever 1 week before this episode. So you can see that there is a diffuse scleritis-like picture. And you can see multiple necrotic areas like this. And this looks like more of a necrotizing scleritis kind of a picture. So with the help of the pediatrician, we started the child on antibiotics, and with the steroids, the eye was quiet. So never to forget this condition. This is the most dreaded condition and very common to see in children. You get all kinds of injuries, a pencil injury, a broom injury, a stick injury, a knife injury. All this can land up in this position. So you have to be wary of this condition as well, the traumatic endophthalmitis. And this child, so as I told, a general physical examination is very mandatory. The child was brought with congestion, and you can see that there is a lid coloboma, there are multiple, there's a preauricular tag, there's a macrosomia, it's a case of a golden heart syndrome. So you can have this kind of syndromic child also coming up to your OP, and you should be wary that all this is possible. So this is because of the exposure, because of the lid coloboma, and that the child had developed redness. So thank you all for the patient hearing.
I think what was key through every presentation is the need for a complete eye exam. Very often, as in our adult patients, the minute you find something significant, the brain switches off and you kind of look at it. I think it's important to go back to our postgraduate days and remember our teachers who insisted on looking at every eye from the eyelid to the retina. And I think every one of the cases, the speakers have reiterated the need to rule out other anomalies. So I don't think this session could have reaffirmed the need for a complete eye exam anymore. The second thing, I think, as pediatric ophthalmologists, that all of us get a little upset and angry at times is we don't see our fellow specialists give importance to refraction and vision rehabilitation. So once they've solved the primary subspecialty issue, often the child is left and are called back for a review after a few years. And many of these children would have an inherent refractive error, which we miss an opportunity at times like this to identify and also rehabilitate. I think that is very, very, very critical. I think what ma'am presented as a part of ROP is, as ophthalmologists, we should not be contented with what we are treating, but try and see, is there something better we can do for our children to minimize or mitigate whatever risks that those children have. And I think the last bit is we've seen nomenclatures change from cortical vision impairment to delayed visual maturation to term to preterm. Essentially, I think we are also understanding a lot of these conditions a lot better. And we also realize that there may be an opportunity for us to stimulate some potential vision in these children. So rather than just branding them as blind, today we do find that vision stimulation at least enhances certain aspects. They may not get the regular visual outcomes that we see in other children, but there is an opportunity for us again to rehabilitate. So giving some hope to the parent ensures that the child are with us and we can subsequently rehabilitate them to try and make them as independent as possible.
I'm sorry to interrupt this session. The session will go on after exactly 30 seconds. The annual general body meeting of the KSOS will happen in this hall. So if we don't have a quorum, we have to call for the meeting first and adjourn it and then restart again. So I'm now calling the general body to order. And since there is no quorum, this meeting is adjourned. So we'll reconvene at 5:30. This is to save time. Otherwise, I will have to announce at 5:30 and then we can start only at 6. Sorry for the interruption. Thank you, Kaushik.
So as sir has already told the points that we have to remember, the other thing that we have to remember is about the importance of history taking. So what we can do is the history has to be very taken probably in our OP, which is with full, I mean it's in full rush. You may not get time, but I think children are the ones who cannot complain of anything. And to do justice to the children, you need to be having little bit patience and deal with them each one-to-one case. And many things you can come to a diagnosis just by history taking itself. So I would highlight that point as well, especially in cases of CVI. Whenever a child comes telling that the child is not looking at the face of the child, face of the mother. So that's one important history that we have to be wary of. And a premature child, like what Dr. Ghana has already told, after ruling out retinopathy of prematurity, after 6 months of that, even in spite of that the child is not looking at the face of the mother, you have to be wary of the condition of CVI as well. So that's very important because early intervention in this child will help in further development of the child whole in all, like a gross motor development, a fine motor development, everything depends upon the vision. So how early you start intervening the child, that much of development the child can have in future. So anything you want to add?
Hello. One point I would like to add is from the discharge summary itself, we will know if the child has had a very stormy neonatal period or not, and if the child was preterm or not. So what we can do is we can basically classify the children as the one who are high suspects for CVI, and it is better to call them at the age of their corrected 3 months of age. By 3 months of age, the child should be having a social smile, at least by 3 to 4 months of age. So then we can catch those children early also. And one point I would like to add regarding watering of eyes in children, many a times the problem is not with the eyes. Of course, we have to do a thorough evaluation of the eye, including a cycloplegic refraction. Many a times the problem is with the nose. They have severe allergic rhinitis, and that many a times the symptom is watering of the eyes. I am myself a person who has severe allergic rhinitis, and when I have it, most of the people think I have an acute conjunctivitis. And I have to convince them this is not the issue with my eye, it is with the nose. So always try to rule out that aspect, and if we keep treating the eyes for that aspect of the watering without addressing the allergic rhinitis, it won't subside. So it is better always to get an ENT consultation. Just by looking through the nostrils itself, we will know if there is a pale mucosa and if there is allergic conjunctivitis.
Talking about that, recently I had a child, a 7-year-old. Her parents came saying that she was having recurrent discharge and watering from her right eye. When I asked if she had any history of watering in soon after birth, they denied that, saying that the complaint started just 2 years ago. So, but they also gave a history of her having recurrent infections, especially running nose. And I sent her for an ENT consultation, and the consultant got back saying that the child had atrophic rhinitis. So now we will have to see whether the treatment relieves her simulated obstruction that we might be looking at. So the importance of endoscope, the ENT evaluation also in children, neonates who are born with dacrocystocele. Often there is an extension into the inferior meatus in the form of intranasal cysts. So sometimes it can be even fatal to the child's birth because it can cause respiratory distress. So the moment you see a dacrocystocele, which is usually a bluish sac, you need to send for an ENT evaluation, and under endoscopic scopy you have to view if there are any cysts within. If so, they may even need to be marsupialized.
With regard to the tarsal foreign body, it's always difficult to, not difficult, the child becomes very apprehensive when you are trying to evert. So one thing is you have to keep it till the end. Keep everything ready, keep the buds ready, everything ready. And before suspecting, what you can do is you can do the staining of the cornea. If there is a tarsal foreign body, some amount of vertical corneal aberration will be there, then your index, suspicion index goes higher. And in children, most of the time the eversion is not very painful. The fear is because of the apprehension. So just what I do is I don't tell them. I just ask them to look down and I'll gently evert. And keep everything ready and you just remove it. So that is one thing you can try it out.
As Dr. Nirmal has already told, fluorescent staining is very important. Like you can detect whether it's because of the rubbing, which part of the area is being stained in the cornea. So accordingly you can decide where the problem is, whether it is in the upper lid, whether there's some problem, foreign body in the lower lid or some other thing. So depending upon the staining pattern itself, you can make out what problem the child is having. And the other thing that I wanted to add was with respect to the lacrimation, watering of the eyes. So most of the kids with CNLDO, they respond very well to massaging. So if the massaging is done very well, you can avoid many other complications, and this has to be done earlier on. So I would like to ask Dr. Anju about that as well.
So regarding the method of massaging, often when you ask parents how they have been doing massaging, they would show actions like this or like this and all that. So it is important to teach them the right technique. So we start right at the medial canthal region, and it should be given in such a way that the pressure is on the lacrimal sac and not just anywhere around. So what we advise parents is, especially for children, who are less than 1 year of age. We ask them to use their little finger for massage, the parents. We ask them to cut the nails and give good enough pressure and bring it down all the way till here, till this part of the nose. So this has to be repeated at least 50 to 100 times a day. And we demonstrate it on the parents and show them how much force has to be applied and not just simple stroking. So repeated massaging can lead to excoriation of the skin. So we can advise applying a little bit of antibiotic so that it will give a little lubricating feel when they do the massage. And
another thing with regard to the massage is that we are basically using the hydrostatic pressure. So even when we advise multiple times, it is pertinent to give a gap of maybe 3 or 4 hours, because we want the lacrimal sac to get filled up, and then only when you massage, the hydrostatic pressure will cause opening up of the obstruction. So maybe in a gap of over 3-4 hours, thrice a day, 10 strokes. Because we are advising multiple strokes because we don't know which stroke they are going to do it correctly. So if we say only one, it might not just work out.
So the thing that I figured works is to tell the mother saying do it before every feed. So that kind of divides it through the day. And I tell them saying, look, your baby is going to cry.
Yeah.
So the minute you do the massage, clean it and give a feed, it becomes a comfort feed. The child is also comfortable. So don't break your head. So there is no question of the mother forgetting. Otherwise, whether they've done 50, 100, it becomes a very arbitrary. So just telling them do 15 strokes before every feed kind of works.
One thing I would like to add on that is my child had NLD obstruction, and one side it went off by 6 months, and the other I had to do a probe. So what helped was, I think, massaging during feeding is also helpful, because that is my practical experience. So that is easier to do. One more thing regarding that watering part, like Anju told, this uniocular watering with especially purulent discharge. With nasal discharge, especially till maybe 2 to 3 weeks or few months of nasal discharge, only on one nose. And we need to ask a history of foreign body also. Sometimes foreign body in the nose, they present with watering in one eye alone, that like an acquired thing. And third thing, what I needed to add on my talk itself, I think, pediatricians usually ask if it is a cerebral visual or a cortical visual impairment, whether there will be optic disc pallor. So since the child has pallor, it's not a cortical. Why is it a cortical? So it is different from adult cortical blindness. In pediatric age group, when they get a hypoxic ischemic encephalopathy, the retrogeniculate pathway is involved, and they tend to get a pallor as well, because it's a metabolic concept. So it's not a completely neurological thing alone. So they tend to get disc pallor as well. So that is one differentiating factor.
Dr. Siju.
One thing I wanted to add regarding massaging is we should remember that these parents aren't professionals. They don't know about the real location of the sac. So it is not exactly medial canthus. It's slightly below and slightly temporal to the medial canthus, below and temporal to the medial canthus. And more than what I generally tell my patients is, parents of patients is, not the massage all over like a line, but rather a cyclical action in that location. I train them. Every time the parents come to me, I hold their fingers. I take them there into the child's tear trough area on the sac. I make them feel that area. And then ask them to do a cyclical action, because they won't really press the sac unless they really know where it is exactly located. So yeah, cyclical action, and they see the result. They see the roplast, and then continue. So this has helped to prevent a lot of cases where which would have otherwise led to children requiring probing under GA.
I think the GB will be, probably the GB will be conducted in this hall. So any doubt, we are always available outside, so you can ask anything. Thank you.